Hey guys, let's do kidney. So, what do you need to know about kidney? Not too much, I'll be honest. Okay, you do need to know what a chronic kidney disease is. Very little of it. You only need to know that chronic kidney disease is irreversible, and if allowed to progress, it's a disease that kills you. It leads to chronic renal failure. Chronic renal failure is deadly unless you get a new kidney, renal transplant, or you, hopefully you get it in the end, but you have to get dialysis before you get it. Okay. So there are different stages of chronic kidney disease. Once again, it goes downhill, but there is one stage that you kind of need to focus on. It's at stage 3 of the chronic kidney disease that you see patients starting to show, the disease raises its ugly head. You start seeing symptoms in patients. Remember, symptoms is what the patient complains about. Okay. And this is when glomerular filtration rate drops below 60. Normal is 100. Most of you in your 20s have above 120. Okay. So, when glomerular filtration rate drops below 60, kidneys are, and definitely below 29. So GFR between glomerular filtration rate, GFR between 60 and less than 60 and more than 29. So 30 to 59 is considered to be stage 3. Now, the problem is that it's a pretty severe kidney function loss if it's around 29. Okay, so patient absolutely does require dialysis. Okay, or you see symptoms. All right, so the only reason I started off with this is because I want to mention this term GFR. GFR stands for glomerular filtration rate, and you did this in your pathology classes, anatomy. So let me remind you some anatomy and physiology. This is very important because otherwise you won't be really, you can't really talk about this. Okay, so you remember the Bowman's capsule, right? That's the capsule. That's the capsule. It looks like a cup, Bowman's capsule. If you don't remember it, go back and watch my videos for anatomy. Okay. So Bowman's capsule is where the blood vessels are. So first of all, we have afferent as in A, the first letter of the alphabet. Afferent. We have efferent, E as in exit, A as in arriving arteries. Arriving arteries, exiting arteries. Afferent, efferent arteries, okay? And these arteries then come here and form a little ball of, these are arterioles, the little arteries. These arterioles come here to the capsule, to the cup, okay, Bowman's capsule, and form a little ball of blood vessels that kind of increases the pressure, and therefore this blood gets filtered properly. Bowman's capsule. Filtered means what? It just makes urine, nothing else. You basically put blood under so much pressure that a little bit of water leaks through the blood vessels. Okay, and we call that a little bit of leak urine. Urine at that level is essentially a filtrate of blood. Okay, just water. perfectly sterile. Okay, filtered water, ultra filtrate is the term. Okay, now so here's the cup and a little bit drip, drip, drip. That's your urine. Now it starts running down those tubules. Excuse me. There is proximal, there is loop, and then there is distal tubule, and there is a collecting duct, right? Collecting duct empties into the into further down the road into larger areas, and we'll talk about them in a second. Okay, so right now just think about the nephron. Nephron is the smallest part of the kidney, and I just described the nephron to you. The Bowman's capsule and the tubules. There are about 1 million of them, and they all empty into the collecting ducts. Okay, so that's very important. What happens here? You have afferent arterioles and you have efferent arterioles. The ones that come in, the ones that leave, and what do you do to them? They form a little ball where they leak a little bit of water because of pressure. You collect that water, and that water runs down those tubules, proximal, distal, and in the middle is the loop of Henle, right? And that distal is obviously very far, proximal is obviously very close. In between there is a loop of Henle. Okay, so those distal tubules empty into the collecting ducts. A single nephron is the cup, the Bowman's capsule, and the tubules, proximal, loop, and distal. Okay, those empty into the collecting ducts, which receive urine from many nephrons. Okay, and obviously in that nephron, what you filter at first into the capsule, that gets processed, right? And that's why we need the kidney to process it. Okay, so if you can't process that urine, that's chronic kidney disease, which is irreversible, which can lead to chronic renal failure, requiring hemolysis and kidney transplantation, right? And it goes downhill at stage 3s when you're going to see it. All right, so now let's talk about this glomerular filtration rate, but more so the place where it gets, where blood gets filtered. Okay, so that the cup is contains that collection of blood vessels called the glomerulus, the ball of capillaries, right? So arterioles out. And what happens? What can happen in that area is that there might be a disease. What if that area, the nephron itself, is damaged? What is the function of the nephron? The cup and the tubules to filter blood, make that urine, take back a little bit of that water, take back a little bit of that salt, but still make the urine, right? Toward the end, proximal, loop, distal, what's going to happen? That urine will go into the collecting ducts and then empty into the eventually into the bladder, right? So what if that nephron is damaged? Well, then obviously you won't be able to filter blood. Okay, so in cases, and so now I want to bring you to where your material talks about pre-renal, renal, and post-renal azotemia. Okay, renal azotemia is damage to the nephron, Bowman's capsule, or the glomerulus, or the tubules, okay, such that you cannot make urine. Examples of that to that system, okay, so examples of that would be nephrotic syndrome. Nephrotic syndrome, there are many, you will learn nephritic, nephrotic, nephritic, nephrotic, as you go into your, as you do more and more of your pathology, pathophysiology in the core. But what you need to know is that patients with damage to this nephron is the unit of the kidney, right? There are 1 million of nephrons in the kidney that filter blood, right? Nephrotic syndrome results in damage to these nephrons in a way that kidney can no longer filter filter blood properly. And what happens is that you lose too much protein. Okay, and if any one of you has ever taken the egg white, and many of you probably have, and try to beat it with, to create foam, you're going to see, I mean, take some of that of egg white and put it in water. I mean, how easy it is to foam, right? Same thing happens to urine. If a patient loses too much protein, patient's urine will be very foamy. That's due to extremely high content of urine, and there is a value to that, 3.5 grams, which we'll learn later on. But those patients lose a lot of protein. Just know, a lot of protein. Obviously, protein is what? Your muscles. Protein is what? Your immunoglobulins, your antibodies, and so on. So it will affect your body, right? In the end. But just know that you lose a lot of protein. And when we do analysis, when we examine urine, analyze urine, right? The term for that is urinalysis. We see a lot of protein. So urinalysis is the first test done to diagnose the nephrotic syndrome. Nephrotic syndrome is too much protein in urine, and the urine is foaming. Okay. Another way to, and that happens in the area of the capsule. Okay, in the area of the capsule. May also happen in the area of the glomerulus, because there is that filter made up of the basement membrane on one side, in the middle, and the capillaries have that endothelium, the fenestrated layer of endothelium with fenestrae, which are windows in the basically gaps in the among the cells, right? So that blood can actually squeeze through, sort of. Okay, so there is a endothelium, there is a basement membrane, and on this side there are podocyte food processes, right? So damage to any part of this filtering system is a damage to the glomerulus portion, okay? But there can also be a damage to this portion, the Bowman's capsule or the glomerulus, which is essentially nothing but the blood vessels, okay? So what if there is a damage to the tubules? And we don't say inflammation of the glomerulus. We say acute or chronic tubular damage, tubular. And there is a disease, there is a pathology that you need to know. It's called acute, that means happens very quickly, acute tubular necrosis. Tubular necrosis, death of the tubules. Obviously, what that means is the death of the, so this is your tubule. It's a hollow portion because urine runs through, right? But it's the death of these cells surrounding the portion of the tubule that come in contact with urine. Okay, so acute tubular necrosis is death of these tubular epithelial cells in the renal tubules of the kidney. Okay, that's obviously not a good thing. Why? So cells die and slough off. They're dead. What happens if too many of them die and slough off? They block urinary flow. What happens if you block urinary flow? Urine cannot go through. What's the function of urine? urine is a cleaning, basically is a way to clean your body of urea, for example, okay? Okay, what if you can't do it? Urea will stay in blood and the patient will die. Think of gastrointestinal videos. Think what happens if you can't filter hemoglobin that gets broken down into bilirubin. So cells, the red blood cells die. Whatever that heme is gets broken down further into hemoglobin. And whatever that hemoglobin is gets separated, heme, globin, and heme finally gets broken down further into bilirubin, and that bilirubin is a part of bile, right? So what if you can't take that bilirubin and incorporate it into bile? Well, it builds up, it goes back, reflux, like gastroesophageal reflux disease, reflux, and patient gets jaundice, yellow eyes, jaundice, right? Same thing happens with urine. You won't be able to get rid of urea. Patient will have problems with too much urea, okay? All right, so acute tubular necrosis is one way to kill the unit of the kidney, the nephrons. The other way would be, for example, nephrotic syndrome, where the Bowman's capsule and the glomerulus are damaged, okay? So, and this is renal damage. Everything before that, what is before that? The whole cardiovascular system, sort of. The blood feeding into the glomerulus is before that. And everything after the collecting duct, remember, collecting duct is where the distal tubule empties into, remember, glomerulus here, Bowman's capsule, proximal, distal loop in the middle, distal, all these distal tubules of each of the glomerula empty into this thing called collecting duct, okay? So collecting, starting with the collecting ducts, we have a collecting system of urine, okay? So collecting duct empties into the renal pelvis, okay? And you have those minor calyces, you have major calyces, which are part of the pelvis, and basically pelvis empties into the ureters, and ureters empty, they're ureters, ureters empty into the bladder, bladder empties into the urethra. There is only one urethra, right? And that's how you pee out. All right, so if there is a block anywhere after urine has already been made and poured into the renal pelvis, the kidney at a macroscopic level, basically, we call it post-renal. Because when we say renal damage, we mean glomerulus and the tubules only. Please remember that, okay? So pre-renal azotemia can be due to acute kidney injury, okay? Pre-renal azotemia can cause problems of its own. How do you get pre-renal azotemia? Well, what did I say? What is pre-renal? Pre-renal means blood coming to the kidney. There is some problem with that. Okay, how can you have problems with that? Well, what if someone is a marathon runner and is totally dehydrated? Marathon runner, somewhere in Vegas, not a very good combination if you're not hydrating, okay? What if someone had a major motor vehicle accident, lost a lot of blood? How is that blood going to come to the kidney? That's why you want to give that patient volume, give them a lot of normal saline, ASAP, okay? Or there may be anatomical abnormalities and many other causes, okay? But what happens that lead to many other causes that result in less of a blood flow to that system, to that nephron. Okay. Now, less blood flow, and therefore pre-renal azotemia, which leads to acute renal injury, acute kidney injury, or renal. You can use this term interchangeably. Basically, kidney can't function because you don't have that thing that is supposed to be going to the kidney. That's blood. Okay, so dysfunction ensues. Okay, so pre-renal is marathon, pre-renal is motor vehicle accident because of too little blood. Okay, renal is damage to that nephron, the glomerulus plus the tubules, proximal, distal, and in the middle of it, the loop. Okay, now if there is a pre-renal, if there is a renal, there is also post-renal damage. Okay, and post-renal injury can result in post-renal azotemia. And these are what can happen is that what happens is what we call obstructive uropathy, because urine is already made. Now we obstruct it. We don't let it flow out. Okay, so there is a damage to a normal function of urine formation and emptying that glomerular area of the urine it has made. Okay, so there is a backup of urine because normal urine can't flow down. There is a backup of urine, and we call it uropathy, basically any disease or disorder of the urinary tract. But what happens is that, for example, depending on where it happens, you might have renal pelvis dilation. Remember, there is a cortex, there is a medulla. That's where the glomerulus and the tubules are, right? And then there is this pelvis. That's where the collecting tubules empty into. Okay, and if there is, for example, so much of that urine accumulation in the kidneys, okay, after the collecting ducts, that the pelvis is dilated and kidneys can become pretty large. Okay, we call it hydrowater nephrosis. Osis is a chronic condition. Hydro is water, nephr is kidney. Hydronephrosis. Okay, so dilation of the renal pelvis. You also have parts of the pelvis called calyces, minor, major calyces. Minor are the smaller ones. That's where the collecting ducts empty into, the renal pyramids empty into, right? The collecting ducts. So pelvis, just think pelvis dilatation of the pelvis due to obstruction of urine flow somewhere after the pelvis. That's your hydronephrosis. Okay. What can cause that? Well, anything that comes after the pelvis, right? What comes after the pelvis? Ureters. That's right. What comes after the ureters? The bladder. What comes after the bladder? Urethra. So let's say there is a stone, urinary stone, that is made somewhere in the pelvis, and it just rolls down the ureters and blocks off the ureteropelvic junction. Okay, there is a very severe narrowing where let me take it, walk it back. There is a narrow part where ureter enters the bladder. That's a narrowing. Okay, so if there is a stone formed somewhere in the ureter, it comes down and hits that narrowing. So what's going to happen? That ureter will now have a lot of urine, right? And the pelvis will now have a lot of urine and will simply block off any more urine coming from the collecting ducts, and collecting ducts empty all that urine from the tubules, and tubules are connected to that urine making facility called the Bowman's capsule and the glomerulus, right? So that's not going to work either now. And so Blood coming here would be like, hey, you know, that factory doesn't work, keep going. And patient would have a blood poisoning essentially. Okay, so kidney stone is a bad thing. Obviously, it may cause post-renal azotemia, too much of urea, azotemia, because urea, remember I showed you the formula, it has too much of N. Azotemia comes from the word too much nitrogen. And another word for N is azote. Okay, not used very commonly, but azote stands for nitrogen. So what we're trying to do, we're trying to get rid of all that nitrogen. That's why you're going to read later on nitrogenous wastes. Okay, nitrogen. That's why you need to remember that formula I showed you. I don't want you to be chemists, but I do want you to understand that what we're trying to do is get rid of that amino acid degradation protein. So proteins are made up of amino acids. When we break down proteins, amino acids are produced. Okay, those amino acids have that N, too much of N, nitrogen. We need to get rid of that. So we form urea. Okay, urea is easy to get rid of. And if we don't, it's a problem. And if you have renal, pre-renal, or post-renal azotemia, emia means too much of blood. Azo means nitrogen, too much of nitrogen in blood. That's an inability to get rid of the nitrogenous compounds, too much urea in blood, patient will die. Okay. Post-renal azotemia means too much nitrogen in blood due to kidney stone or other things such as benign prostatic hyperplasia, BPH, and I'll do that in a second, okay? So just know that it's basically an outflow obstruction, okay? Outflow obstruction, which obviously causes acute kidney injury or chronic kidney injury over time, which can lead to dysfunction, okay? And remember that the Greek name of the stone, kidney stone, is kidney stone or renal stone, used interchangeably, is renal calculus. Renal calculus, and calculus is a Latin for a pebble. So it's a renal pebble, essentially, a stone. And they are stones. They're mostly calcium stones, calcium pebbles, okay? And don't forget that blood in urine is called hematuria. Blood in feces is called hematochezia. Melena is a tarry stool in blood. Tarry stool. That was stupid. Melena is tarry stool, so not hematochezia. Hematochezia is blood in stool. Melena is that tarry black consistency, okay, that you see in stool presents with a tarry black consistency, okay? All right, so do know the term benign prostatic hyperplasia. Number one, it's not cancerous. Number two, it's just a large prostate, increase in prostate size. Benign means good, not cancer. Nothing to do with cancer. It's benign, it's good. It's just increase, okay? But what does it do? It increases, and what does it do? Who goes through the prostate? The urethra? So you become so big and strong that you don't fit in your clothes, right? But what if the clothes were, what if you were growing so that, and there is something that you're kind of pushing on? That's what the benign prostatic hyperplasia does. It pushes on that urethra that goes through it and simply doesn't allow urine to pass easily. Okay, it's non-cancerous, remember that, no cancer, but it obstructs the urinary flow. Okay, and how common is it? I mean, 50%, I mentioned it in class, right? Half of every male above 50 more than 90%, that's 9 out of 10 guys, men above 80 will have it, guaranteed. It's a normal thing, essentially. Hopefully we'll be able to treat it, right? And that's pretty nasty. How do you diagnose it? I hope you remember that. It's called digital finger rectal, that's right, rectum exam. So basically, take the finger, put always glove, unless you don't have gloves. Digital rectal exam. Enter the rectum and feel the prostate. You will learn how to do that. It's not done very often anymore, but when I was in med school, there were only 2 reasons, and that was like a few years ago. I mean, 15 years ago, we were taught what are the 2 reasons to not do a digital rectal exam. There are only 2 reasons. One, the patient doesn't have an anus. Patient without an anus obviously would not have an opening to, maybe someone had a surgery or something, right? And the second reason, the examiner doesn't have a finger. It was that important, that recommended. Things change right now. They kind of walked away from that, but from what I hear, good urologists expect their groups to still do it, okay? Digital finger, digit, rectal exam, DRE, is an important part of physical examination, okay? Healthcare assessment for BPH. So don't shy away from it. It helps patients long-term. If you diagnose it, you can help them, okay? So this is a good time to discuss problems with urination. So prostate that squeezes the urethra would basically fill up the bladder, right? Because you won't be able to pee a lot. Patients would like pee a little bit, that's it. Pee a little bit, dribbling, drip, dribbling, okay? And so they're gonna have urinary incontinence, which is terrible. Ladies have their own kind of urinary incontinence, men have their own. But, prostate is one example where a patient cannot pee, the bladder becomes very full, and then it's like a cup which is extremely full. What is going to happen? Well, it'll start dribbling, right? So, and that's called overflow incontinence. Well, we also have urge incontinence where someone needs to run to the restroom, urgent incontinence due to a bladder, urinary bladder, that simply has to go. Kids have it due to developmental, they're just not fully developed, okay, yet, the urinary system. And you know that, all of you know, all of you have spoken to little kids where you're talking to them and all of a sudden, little Johnny's gotta go. And after, what seems like a second or two, little Johnny's back. He just ran to the restroom, emptied himself, and is back. Urge incontinence. This is due to overactive bladder. Their bladder responds to the urge right away, okay? Urge incontinence is due to overactive bladder. There is another incontinence called stress incontinence. For example, due to, in some patients, this can be due to coughing, due to laughter. Basically, there is an inability of one of the sphincters, and sphincters are simply doors that block urine from going on the outside, right? The doors leading from the bladder to the outside world, to the toilet bowl, okay? There is one internal door, there is one external door, there is one internal sphincter, there is one external sphincter, okay? So when the internal sphincter doesn't work, a little bit of urine goes through and some dribbling is possible. And that may be due to laughter, that may be due to coughing, basically a poorly functioning sphincter. And then you can have a mix of urge and stress, and we call it mixed incontinence, but it can be mixed features of different kinds. Okay. There are two more kinds of incontinence that I want to mention. One is a neurogenic bladder, and that's like any, it's like mixed incontinence. It can be pretty much anything, but it can be urge, it can be stress, overflow, mixed, and so on. Okay, but then there is one very sad type of incontinence. It's called functional incontinence. Okay, and functional incontinence presents in patients that can't really get to where they should be going, but know they got to go there. So, for example, a patient has Alzheimer's disease, right? Patient knows he or she needs to go to the restroom. Patient does not remember where the restroom is. He's walking around, and we've had a presentation, Alzheimer's disease, but it's kind of different when you've actually seen a patient with dementia walking around looking for their room in a hospital. You will get a different respect for the pain they're feeling. It's a horrible disease, and with the number of patients going up in terms of age, we do have more and more of these patients. So I was actually, it was before my med school years. I saw a patient who was literally walking around trying to remember where his room was. He didn't remember it, and it was very sad. You could see that embarrassment on that patient's face. He tried to smile. He was walking around the hallway, and the only reason he was walking around the hallway was because he couldn't remember which room he was in. Okay, and he was embarrassed to ask. That's how it starts. Okay, so it's a terrible thing. Another reason for functional incontinence would be a patient with, for example, stroke. Patient with stroke is lying in bed. Let's say the right leg is paralyzed, right? Can he or she walk? No. Does he or she know where the bathroom is? Yes. Can he or she get there? The answer. So functional incontinence. Once again, 4 types. There are 4 main types. Urge, due to overactive bladder. Stress, due to poor functioning of the internal sphincter. Overflow incontinence, where, for example, benign prostatic hyperplasia, bladder is just so full that it just flows over. Okay, and there can be neurogenic bladder, where due to a damage to, for example, nervous system in the spinal cord, right? Motor vehicle accident. Herniation of the disc. We studied hernia in the week 4, right? Herniation of the disc, damage to the vertebral body can cause disc herniation, right? The prolapse of the nucleus pulposus can hit the spinal cord nerves, and the patient may lose ability to control the bladder, neurogenic bladder, okay? And the functional incontinence or a mix thereof, features of different types. Okay, so urinary incontinence, terrible thing, terrible thing. Okay, and should be taken care of ASAP, because why do you want to postpone that pain? So at some point, talk to your patients. Talk to them, tell them that we have relatively good way to treat them. So okay. So pretty much the only, so we did talk about the bladder. I also want to remind to you that I'm actually going through a material right now. Okay, so we kind of talked about digital rectal exam. Benign prostatic hyperplasia is non-cancerous. When you think about cancer, you want to know, like in men, in young men, for example, right? Testicular cancer is pretty common, right? So testicular cancer, how do you treat it? orchidectomy, orchidectomy or orchiectomy. They're both are the same word. Orchiectomy. You're removing the testes. Okay, you must perform orchidectomy in patients with testicular cancer. There is, and then they get treated. Okay, so do not. So that's testicular cancer, but BPH is a non-cancer. It's benign. It's in the name, benign prostatic hyperplasia. Okay, so now let me go back to urinary overflow, for example. Let's say someone has dribbling, right? Those patients are at increased risk for urinary tract infections. Okay, urinary tract infections. What is the most common bug that causes urinary tract infection? Well, Escherichia coli. E. coli is the most common bug. You got to know it. You got to know it because, for example, among ladies, 25% of females will have a UTI in their life. Once you have it, you have a risk of recurrence, right? 50% of males above 50 will have BPH. 90% of males above 80 will have BPH, benign prostatic hyperplasia. 25% of ladies will have a urinary tract infection, most commonly due to E. coli. Coli stands for C-O-L-I, means colon of the colon. C-O-L-I is a Greek declination meaning of the colon. So it's the Escherichia of the colon. Escherichia was the name given after the scientist who discovered it. E. coli is how we abbreviate it. Escherichia coli, Escherichia of the colon. They live in the colon. Colon is very close to the vulva, right? So bacteria simply enter vagina, go up the urethra, go up the bladder, go up the ureters, and may even reach kidney. That's your pyelonephritis. Okay, so Escherichia coli. I believe that's pretty much it. I don't see anything else that I can talk about in this short video. Obviously, we talk more in the class, and I hope you use this video and as some kind of foundation and grow upon, and develop, add more to it. Just remember pre-renal, renal, post-renal azotemia, BPH, post-renal azotemia, stones, urinary stones, calculi, right? And urinary incontinence. Those are the terms you gotta know. All right. I will see you soon.